Evening, everybody. It gives me great pleasure to introduce you to Unnati, who's currently in charge of the hospital where I trained for my post-graduation. She has spent a long time with my teacher and mentor, Dr. Jyotsna Joshi, and therefore, eyes closed, I know she'll be impeccable and a great session awaits you. Welcome to you, Unnati, and it's really nice to see you. It's always lovely to see your smiling face. So over to you.
Thank you, madam. I hope I'm audible.
Absolutely.
Yes, thank you so much, madam, for this invitation. Can I share my screen and start off?
Absolutely. And all of you, keep it interactive. Keep sending your messages on chat. I will answer that. And the end, we can ask Unnati for, her replies. Over to you, Unnati.
Yes.
Thank you.
Is my PPT visible?
Yes, my madam.
Yeah. So, as madam has already introduced, we would be dealing with, or we will be speaking today on interstitial lung disease and post-COVID pulmonary fibrosis or post-COVID ILD, or the various names as we know of. Okay. A lot of my PPT is taken from my own department, and I thank my department and our former professor and head, Madam Joshi, who has taught me a lot on ILD, and Dr. Ketki, my colleague, for sharing the PPT with me. So before we move on to understand interstitial lung diseases, we should know exactly what is pulmonary interstitial, or where do the ILDs affect. So ILDs affect an area known as the pulmonary interstitium, which is nothing but it is the alveolo-capillary basement membrane. This is the same membrane through which diffusion for oxygen and carbon monoxide takes place. So basically, this membrane contains the alveolar epithelium on one side, the interstitium in between, and the capillary endothelium on the other side. So ILDs basically involve all these components, and though we call them as interstitial lung diseases, that is usually involvement of the alveolar capillary basement membrane. So what is the pathogenesis in ILD? It is said that in ILD, you have repetitive injury to the alveolar epithelium. And this could be due to numerous causes, various causes. We will see the etiology further. But these inflammatory processes and this repetitive injury causes a cascade of reactions wherein you have attempts to tissue repair and injury, tissue repair and injury, wherein you could have scarring, structural changes, and the result of which you have basically interstitial fibrosis or an end-stage interstitial lung disease. Coming to why do you get, or why is the alveolo-capillary basement membrane, or why is the interstitium involved, and what are the causes? Now, ILDs can be very broadly classified into known ILDs due to known causes and ILDs due to unknown or idiopathic causes. So what are the known causes of ILD? ILD can occur because of the exposure of the interstitium to various environmental factors or environmental triggers, or what we call them as environmental dusts. Okay, so you could have occupational diseases or occupational lung diseases like pneumoconiosis, which are due to exposure to the inorganic dust. You have diseases due to exposure to organic dust, which are known as hypersensitivity pneumonitis. You have connective tissue diseases or autoimmune diseases, which involve the lung as well as the other areas which have connective tissue. So this include the rheumatoid arthritis, systemic sclerosis, SLE, and we have multisystemic diseases like sarcoidosis, which can cause interstitial lung disease. Now, there are certain infections like miliary tuberculosis and eosinophilias, pulmonary eosinophilias, which also mimic an ILD or behave like an ILD. You have very rare diseases, lung diseases, which can occur due to, say, vaginous granulomatosis, or due to certain drugs, which could be common drugs like amiodarone or methotrexate, or chemotherapeutic drugs like bleomycin, which can cause pulmonary fibrosis and an ILD. Okay. Now, coming to the most common ILDs that we see, or a common type of interstitial lung diseases where we take the history, we are often not able to identify what is the cause. So interstitial lung diseases are also broadly classified as, it was always taught to us as, due to known causes, or diffuse parenchymal lung disease is an older term used for ILDs, and they are due to known causes, as we have seen the number of causes. They are IIPs, or idiopathic interstitial pneumonias. They could be because of granulomatous diffuse parenchymal lung diseases like sarcoidosis, and you could have other causes. Now, the idiopathic interstitial pneumonias, or the idiopathic ILDs, are classified as per the American Thoracic Society or the European Respiratory Society 2013 classification into a major group of, or major IIPs, which consist of something known as a chronic fibrosing interstitial pneumonia. So basically, these diseases have a chronic course and they have fibrosis. That is why they are known as chronic fibrosing interstitial pneumonia, and these consist of idiopathic pulmonary fibrosis and fibrotic NSIP. Then you have IIPs which are very classically seen in smokers. These include the RBILD, or respiratory bronchiolitis associated interstitial lung disease, and a desquamative interstitial pneumonias, or DIPs. Then there are certain ILDs which are very acute or subacute in onset. So they would mimic a critically ill, lung or an ARDS-like picture, which is often seen in acute interstitial pneumonias, and a subacute presentation is often seen in cryptogenic organizing pneumonias, or COP. There are very other rare idiopathic interstitial pneumonias known. They are rarely seen in literature, rarely seen in a practice. However, to name a few, you have idiopathic LIP. There is a lymphoid interstitial pneumonia that happens and is often seen in HIV positive patients, where you have a known cause, but you can have idiopathic lymphoid interstitial pneumonias. There are other rarer variants which are very rarely seen. Say, once in 5 or 10 years, you would get a case of idiopathic pleuroparenchymal fibroelastosis, and there is airway-centered interstitial pulmonary fibrosis. The most common ones are this first 6, where we have IPF, fibrotic NSIP, RBILD, DIP, cough, and very rarely AIP. Usually, it is difficult to diagnose an AIP because the patient is very critically ill when it presents. So, before we move ahead and see the clinical presentation of ILDs, we should know a common ILD, which is very common in practice, which is known as hypersensitivity pneumonitis. As we discuss, HP, or hypersensitivity pneumonitis, is an ILD which happens due to exposure to organic dust. Okay. Now, there have been, if you read the respiratory textbooks of Fishman or Crofton, you will get a 2-page full of, causes, or, say the disease. There have been various names given to different types of HPs, the source of exposure, and the responsible antigens. Most commonly, what we see in practice are exposures to pigeon dust in Mumbai. We see farmers with what is known as the, farmer's lung, okay, which is due to exposure to the moldy hay. But whatever said and done, irrespective of the exposure, it is an HP-like picture or a hypersensitivity pneumonitis-like picture. It is most important because the treatment for any type of HP is the same. Then, as we discussed, inorganic dust exposures causes pneumoconiosis. The commonest ones which are seen are when you have exposure to coal, often seen in coal miners, you have coal workers pneumoconiosis. When you have exposure to silica, which is more commoner, you have people who do sand blasting, who do who work on the roads with the concrete, and those, especially those who work in the flour mills and use, the agra stone, which contains silica for grinding in the old time flour mills, often have silicosis. Then there is a disease known as asbestosis, which is often seen in occupations like minings, or people who are involved in the insulation work, etc. Now, coming to, irrespective of the cause of ILD, we should know how will an ILD patient present. So, an interstitial lung disease patient will present with a progressive dyspnea or a breathlessness, which would be this on exertion, and there would be a persistent dry cough. Often, some patients may have just a dry cough, or some may have dyspnea. One of the symptoms may be predominant, but usually these are the usual complaints. Okay. Rarely, like in this week, we had a reference from the rheumatological ward, wherein a patient was admitted, wherein a patient with systemic sclerosis was admitted with sclerodactyly, dysphagia, and rheumatological complaints or complaints related to connective tissue disease. And when on asking her repeatedly, she said, yeah, she gave history of dyspnea on exertion grade 1. So they may not come out with respiratory symptoms, or they may have minimal respiratory symptoms and may be admitted or referred to you by the dermatologist or the rheumatologist, especially in the multisystemic or the connective tissue diseases. Often there is an abnormal chest X-ray for which you are being referred to, or a pulmonologist is called in. But we should remember that whenever we see a patient of multisystemic disease or a connective tissue disease, the X-ray may be normal and still there may be early ILD which may not be picked up on an X-ray. Now, very, very, very rarely, we often have a patient being referred with an abnormal PFT. Now, it is ideally taught, and as you must have seen in your lectures previously, that you should always read the PFT in clinico-radiological correlation. So, a history would be important. When you ask proper history, you should get some history of a dry cough or a persistent cough or dyspnea. And when you interpret the PFT as a restrictive abnormality or an abnormal PFT, which indicates or which falls into the diagnosis of interstitial lung disease. Very, very, very rarely, an ILD may present in an acute exacerbation. Basically, interstitial lung disease patients are often have they have a stable, they may have a stable course, they may have a cough or breathlessness. These are elderly individuals. They often think that the cough, the breathlessness is because of probably aging process and all. And then when they have hypoxemia, when they are in respiratory failure, is when they actually present to the hospital. So rarely you may not have a pre-existing diagnosis of ILD and the patient may present in acute exacerbation to you. So an ILD is usually diagnosed on the basis of, so then a patient of ILD is usually a patient with a dry cough or a dry cough, persistent dry cough, a progressive breathlessness. Usually these symptoms run for a duration of at least 6 months to a year, till the time the patient really presents to a tertiary care center. The awareness about these diseases has expanded tremendously, and we now see patients of interstitial lung disease or early ILD presenting even much earlier as soon as they are symptomatic, because access to imaging, access to a CT scans is very easy, and there's a lot of awareness even amongst the general practitioners about interstitial lung disease, that when they see an X-ray with when they see such a patient and they do an X-ray and they see reticular opacities on an X-ray, they suspect an ILD and often investigate them with a high resolution computed tomograph. Now, patients of interstitial lung disease often present to a tertiary care center in later stages, wherein they will have right heart failure. They will have cor pulmonale, and they may present with right heart failure, wherein they will have increased breathlessness, pedal edema, generalized anasarca, ascites. Okay, patients of interstitial lung disease have always to be asked about history wherever you suspect ILD. So you have a person who has dry cough, progressive breathlessness, and you do not have any other features, or you have ruled out an asthma or a COPD and you're strongly suspecting an ILD, you would further take your history down to understand what is the cause of it. When you don't have a cause on a history, is when you will call it an idiopathic ILD. Otherwise, you would try to fit it into a known cause. So simple things like asking for features associated like connective tissue disease. So what are they? In rheumatoid arthritis, you can have small joint pain, stiffness. Okay. Then in systemic sclerosis, you can have patients with skin features. Okay. There sometimes maybe myopathies, muscle involvement, and joint problems with which these patients present with. Now you can also ask, need to ask about exposures to organic and inorganic dust. So basically you need to ask about the environment in the home as well as the place of work, which is very important in these ILDs. Then there are certain ILDs which run in families. So a family history is very important in cases where you are suspecting an ILD. certain cases like, post chemotherapy patients, post radiotherapy patients, the drug intake or, radiation exposure history is also very significant to understand that this is a post chemotherapy or a post radiation pulmonary fibrosis and ILD. Now, on clinical examination, interstitial lung disease patients classically sometimes may have a normal saturation if they come to your outpatient department, but they have something known as exercise desaturation. Means when you make them walk and when you achieve a target heart rate, which is 200 minus the age of the patient, there is usually a desaturation. So say the patient saturation is 96, you make the patient walk in such a way that the patient should get a little breathless, and the heart rate should be, suppose the patient is 60-year-old, the patient should achieve a heart rate of 140. And if the saturation falls below 93, so there is more than 3% desaturation, then it is said to be a significant desaturation, and exercise desaturation in the background of a dry cough and a progressive breathlessness goes more in favor of ILD and points more in favor of an interstitial lung disease. ILD patients sometimes may have clubbing. It is not necessary that all ILDs have clubbing, but patients of idiopathic pulmonary fibrosis classically will be clubbed. Now, interstitial lung disease patients have very fine bibasilar and inspiratory velcro crackles of crepitations. These are these are like the velcro. Okay, so like when you rub the velcro apart, okay, or when you pull the velcro apart, these are very fine and they are often end inspiratory, and you will hear them more in the basis. Okay, and when you have a patient of dry cough, progressive breathlessness with exercise desaturation, clubbing if present, and bilateral bibasal velcro crackles, you have clinched the diagnosis of ILD. You go ahead further and do a chest X-ray. The chest X-ray, as is shown here, will show something known as reticular or lines or reticular opacities. As you can see here, there are certain linear opacities seen on the X-ray, which are known as reticular opacities, and there are certain dots or points seen on the X-ray, which are known as nodular opacities. So ILDs classically have reticular nodular opacities. Mind you, an X-ray is not diagnostic of ILD. The same X-ray, if the clinical history is different, suppose you have a patient who has 2 to 3 days, like in the COVID pandemic, we had patients who had 2 days history of fever, 2 days history of cough, and a similar X-ray, you would say this is a COVID pneumonia. Okay, so the history is important. So these are bilateral reticulonodular opacities in a patient with usually a chronic to subacute history of dry cough, breathlessness, and exercise desaturation with bilateral velcro crackles or bibasal crepitations, then it clinches the diagnosis of ILD. There are certain advanced tests which are often available in the outpatient department of a pulmonologist, like the simple spirometry, which you would get a restriction or a restrictive abnormality. So to give you an example of 2 types of ILD in the last week, so my residents told me about 2 patients. So I had a 70-year-old man who presented to my outpatient department with progressive cough and breathlessness since a year. He does not give any positive history of an associated cause, and he doesn't have any comorbid conditions. And he just walked into that OPD saying, "Doctor, I have been to multiple doctors, and my general practitioner said, like, now you go and visit a tertiary care center." He did an X-ray actually, and the general practitioner could not diagnose what it is and said you need to be referred to the tertiary care. And that's how, when we evaluated the patient further, he was clubbed. When we made him walk outside the OPD, and we just checked for an exercise desaturation, it was present, and the gentleman had bilateral bibasal crepitations. In an elderly man with this history and clinical presentation, we have come to and clinched the diagnosis of an ILD, mostly idiopathic pulmonary, IIP, mostly idiopathic pulmonary fibrosis. Okay. As against that, we get a reference from a rheumatological unit. There's a 30-year-old lady who, when they admitted in the rheumatological side, when they asked her, grilled her, they said, yeah, she has dyspnea, grade 1, MMRC grade 1. But that was not a forthcoming complaint. She was basically admitted in the medical ward because she had difficulty to swallow food. She had dysphagia. She was having sclerodactyly, ulcers on the, the fingertips, and she was having other manifestations of systemic sclerosis for which basically she was referred in. These patients may or may not be clubbed, but our patient was clubbed. When we checked her, she had post-exercise desaturation. When we examined her, she had bilateral crepitations. Given the clinical picture, she was a case of systemic sclerosis or scleroderma. And given the findings of, exercise desaturation, crepitations, and dyspnea, she did not complain much of cough, but the dyspnea in the background, and the X-ray was available, which showed bilateral reticulonodular opacity. We made a diagnosis of systemic sclerosis associated an ILD, or an ILD due to a known cause. Okay, so after the history, the next investigation which is available at our disposal or which is important for diagnosis is a chest radiograph or a chest X-ray postero-anterior view. Now, in an X-ray, how do you, describe the opacities or the findings of an ILD? So there is something known as, we'll see the X-ray in the next slide, the thing known as interstitial pattern. So you describe them, or you tell, you say that these are reticular or linear opacities. And when you see nodules, you say they are nodular opacities. And when you see both, you say they are reticulonodular opacities. The terminology of ground glass is ideally to be remitted to an HRCT and is not to be commented on an X-ray. So on an X-ray in an ILD, you will get reticular opacities, nodular opacities, or ideally, as we say, they are bilateral reticulonodular opacities. Okay, there's a huge differential of this X-ray, but given the clinical situation, it would be due to interstitial lung disease. Okay. Now, the X-ray is usually not much contributory towards the diagnosis of a type of ILD, but yes, it helps you in coming to the diagnosis of an interstitial lung disease. You cannot probably predict the etiology. So, an interstitial lung disease patient will have bilateral reticulonodular opacities. There may sometimes in advanced cases be volume loss signs, like here if you see the right diaphragm is elevated, the trachea is slightly shifting to the right side, because as the pulmonary fibrosis advances, and if it is unequal, a side may show signs of volume loss. As you see, this is an X-ray in a patient, probably was done in ICU, and we can see an oxygen tubing also. So coming to the lab evaluation, like in any other respiratory patient, you would need the basic hematological and biochemical tests in any ILD case. So now, is there a role of these tests, and do they help you in identifying the etiology? Yes, there is a role of these tests, because when you manage these patients, you should know the basic hemoglobin, you should know the basic CBC. Now, there are certain interstitial lung diseases or certain eosinophilias which basically present like an interstitial lung disease. To name a few would be the chronic eosinophilic pneumonias and Church-Strauss syndrome. Though they are not classically ILDs or described as ILDs, they present like an ILD. So if you have eosinophilias in a patient who presents like ILD-like symptoms, I would think about an ILD like, I would think about eosinophilias like TP, CEP, and other situations. Now, a liver function test and a renal function test baseline is important in cases of ILD. This is important because you would be giving certain drugs and managing these patients. So you should know their baseline liver and renal function test. There are certain ILDs which are autoimmune in nature, and they are often known to involve the liver, where you have autoimmune hepatitis and lung involvement, or autoimmune involvement of the liver as well as the lung. Similarly, there are certain diseases like vaginous granulomatosis, or anti-glomerular basement membrane diseases, which may involve the kidneys as well as they involve the lung, and these are also known as pulmonary renal syndromes. Okay. Subsequent to that, rarely, this practice is often not followed in Mumbai, but you can have antibodies done to specific antigens. This is not commonly done, but an anti-IgG or IgM could be done to certain common, antigens like the pigeon exposure to pigeon droppings or certain common antigens that are available. More important than these would be in a patient. Suppose you have a lady or a man, specifically in the women who are in their second, third, and the fourth decade. In such patients, when you have findings suggesting a particular connective tissue disease, you should order specific tests. Like you have rheumatology or you have joint pains, joint stiffness, findings that suggest rheumatoid arthritis. You can order a RA factor or anti-CCP antibody. In certain cases where you may have skin involvement, where you can where you have muscle involvement, where you have joint involvement, and ANA or anti-nuclear antibody may be also ordered. In cases like we discussed, the rheumatology reference to us, where we were suspecting it was scleroderma, and anti-double-stranded DNA and the STL70 can also be added to identify or clinch the diagnosis of scleroderma. There are diseases like the Wegener's, which are positive with the ANCA, and the anti-GBM antibody. Anti-GBM antibodies are positive in the anti-GBM disease. Okay, cases like sarcoidosis can have serum and urinary calcium, which may be elevated. Okay. After the lab investigations comes a pulmonary function test. Mind you, pulmonary function test starts from a simple pulse oximetry. So a pulse oximetry may be normal, or you may have baseline desaturation in an interstitial lung disease patient. You classically have exercise desaturation in an interstitial lung disease patient. We do a test known as an arterial blood gas, especially in patients who are admitted to the patient and who often require oxygen. And an arterial blood gas is a baseline arterial blood gas is often indicated even in a stable ILD, because there is a lot of information that the ABG gives us. It tells you about the baseline pH, PCO2, PO2. There is something known as an alveolar arterial gradient, which is calculated by the equation the alveolar oxygen partial pressure of oxygen at the alveolar level minus the PaO2 or the partial pressure of oxygen in the arterial blood. So PaO2 is usually available in the ABG, and the P alveolar oxygen is usually calculated by this formula, which is 150 minus the PaCO2 on the ABG divided by the respiratory quotient, which is 0.8. This is for all patients at sea level. Okay, so an alveolar arterial gradient is usually say between 12 to 16 in normal individuals. As the age increases, for every 10-year rise, in the age, the alveolar arterial gradient is said to rise by 2. However, when the first thing that comes in an ILD is the elevation of this gradient. Okay, so an alveolar arterial gradient, the ABG may often be normal in a stable ILD patient, but they may have an elevated alveolar arterial gradient. Again, this doesn't have much use in practice, but when we teach our MD students or when we teach our UG students, we do teach them to calculate an alveolar arterial gradient. An ABG may be normal, but an alveolar arterial gradient may be abnormal in an ILD case. So we calculate the alveolar arterial gradient. A spirometry in an interstitial lung disease patient will show what is classically known as a restrictive abnormality. It is characterized by a reduction in post vital capacity. There is fibrosis. So what will fibrosis cause? A reduction in the vital capacity. And because there is reduction in the post vital capacity, the FEV1 is also reduced. So you have a low FPC, a low FEV1, and as both are reduced, the ratio is normal. So this is how is the spirometry read in an ILD patient. Now, a diffusion of carbon monoxide can be done on special machines which which study the diffusion capacity of the lung to carbon monoxide. So basically, the theory here is that ILD is basically a diffusion related disease. So early in the disease, when fibrosis has really not set in, you would have a diffusion defect. How do you catch this defect early? It is very difficult to study the diffusion of oxygen. Okay, but we have eventually found out that diffusion of carbon monoxide can be safely and effectively studied, and this correlates with the diffusion of the gases in the lung. So a DLCO is usually done in ILDs who have stable lung functions or good lung functions and who are able to perform the DLCO. The DLCO maneuver is often a tedious maneuver and a breath hold of around 10 seconds is required. So in a patient with advanced interstitial lung disease, they will not be able to perform a DLCO because they would not be able to hold the breath for 10 seconds. But when you are suspecting an ILD and when the spirometry, everything, the patient is a stable patient, when the spirometry is normal, such are the cases where you should go in for a diffusion capacity for carbon monoxide, of the lung for the carbon monoxide, which may be impaired. So, like I have a patient admitted with me currently who is a 70-year-old lady. She is a case of ILD, IIP, IPF. So we did her lung function. The lady always comes with the complaints of I have cough, just do something for the cough. So the lung functions done are more than the FVC is more than 80% of the predicted. So just today we did her DLCO and the DLCO is 44% predicted. So the DLCO is impaired or affected, and yes, this is because of the interstitial lung disease. Another test that we do in interstitial lung disease is to assess the follow-up, which is very important from the follow-up point of view, is also known as the 6-minute walk test, wherein the desaturation during the test as well as the distance covered during the 6-minute walk test, both are important. So prognosis is a lot of prognostic counseling can be done on the basis of how the patient performs the spirometry and the 6-minute walk test. So we have a case here. So this is a 70-year-old lady who has dry cough and progressive dyspnea. She has clubbing. She has bibasilar fine crepitations and she has exercise desaturation. And this PFT report is given to you like this. It's very confusing. So it's always taught to us when you need to read the PFT, just cover what is not needed. So what you need is FVC, you need is FEV1, and you need the FEV1 by FVC ratio. So cover rest of the things which are not required. So we've covered all the other parameters. Next is we will look at the FEV1 by FVC ratio. This ratio, as you can see here, we have to see the actual value, which is 99%, and this is normal. Okay. Then subsequent to this, subsequent to this, we will see the FVC. As you see here, we draw a line on the FVC parameter, right, going till the percentage predicted. As you see here, the percentage predicted FVC is 53%, which is abnormal or low. So this patient has a reduced post vital capacity. Subsequent to this, we have been taught that we will draw a line and the FEV1 parameter and take it right across to the pre and the post bronchodilator value. And as you see here, irrespective of the pre and the post bronchodilator, the FEV1 of the patient is reduced, which is 63 and post bronch 65% predicted. So in this patient, the spirometry shows a reduction in FVC, a reduction in FEV1, and a normal FEV1 by FVC ratio, which is suggestive of a restrictive abnormality consistent with the diagnosis of an interstitial lung disease, mostly idiopathic interstitial pneumonia, mostly IPF, given this clinical situation. As always has been taught to you, PFT is always read in a clinical and if you have an X-ray or radiological correlation. Okay. This is how the DLCO report looks like. You often have the spirometry values here. Okay. And as you see here, you see this patient has a normal FVC. So there is 90% of the predicted. Okay. And you have the DLCO values down. If you will see the DLCO value, it is 52% predicted. The DLCO is often adjusted to hemoglobin of the patient, but still you see, so this is like the case that I described, who was admitted with me. So though the spirometry or, though the FVC is normal, the DLCO is impaired. A DLCO is classified as mild, moderate, or severe impairment, depending on 60 to 80 is mild, moderate is 40 to 60, and less than 40 is severe. Okay. So coming to the next finding, the next investigation that is important in an ILD, which is the high resolution computed tomogram of the thorax. Now, whenever a CT scan is ordered in an ILD, it should be a HRCT, we need to look at the lung parenchyma. So we are going to order a high resolution computed tomogram of the thorax. With that, it should come in the next instance with expiratory scans. The expiratory scans have their own role in diagnosing various types of ILDs, and all centers and all radiologists who read or who report interstitial lung disease always say that, and all clinicians or pulmonologists who diagnose ILDs know the importance of the expiratory scans, and they will always order an HRCT with expiratory scans. It is the same test done in the same sitting. It's just that the patient is asked to hold the breath in expiration and the recuts are done in expiration. Okay, so basically on a high resolution computed tomogram, you will see that this is a lung window or a high resolution window. You will see what is known as interstitial septal thickening. ILD involves the interstitium, causes pulmonary fibrosis or interstitial fibrosis. So you will see linear opacities, or what you see on the X-rays as reticular or linear opacities would be nothing but the interstitial septal thickening. At places, you can see that there are cystic changes or cystic areas. These when these are there are stacks of cysts. When these stacks of cysts are more than 2 to 3 in number, this is known as honeycombing. So we see a CT scan. These are the bases in the image. The base of the bases of the lung or the lower lobes, where we see interstitial interseptal thickening. There is honeycombing seen, okay, and the involvement is usually throughout the lung, and there is no subpleural sparing. Now, there are many other opacities on a CT or other lesions on the CT that are described. So, the first and foremost is the reticular opacities. So, reticular opacities are classically seen in all the common ILDs that present to us, be it idiopathic pulmonary fibrosis, be it connective tissue disease associated ILD, or be it occupational ILDs like asbestosis. Now, there are certain ILDs which we will be discussing further and which we have seen commonly in the last 2 years of the pandemic, which have a haze or a ground glass attenuation. In the pre-COVID era also, ILDs were known, and interstitial lung disease wherein there will be a predominant ground glass attenuation was seen with diseases like hypersensitivity pneumonitis, DIPA and RBILDs. In the post-COVID pandemic or in the COVID pandemic, especially after the wave 1, we saw these ground glass attenuation or ground glass changes on the CT in a patient who had COVID pneumonia, bilateral COVID pneumonia, and it often progressed to pulmonary fibrosis. Now, in interstitial lung diseases like sarcoidosis, you may additionally have nodular opacities or nodules. Other than sarcoidosis, you can have them in HP, in RBILD, in histiocytosis X, and in your pneumoconiosis. Now, the appearance of these nodules, like in sarcoidosis, it is said to be perifissural, and perifissural nodules are there. They can, sometimes the radiologist may be able to tell you what is this type of ILD. These would be, the radiologist will help you in, limiting your differentials on the etiology for the interstitial lung disease. Rarely, ILDs can present with consolidation of the lung. These are very rare ILDs, mind you. They're not very commonly seen, and they are more of a theoretical discussion. Then some ILDs which are rarely seen are like histiocytosis X, LAM, lymphangioliomyomatosis, and PCP, which can present with cysts on a CT scan. Okay, so before we move ahead further, we should know about the HRCT pattern or the high resolution computed tomography criteria for what is known as the usual interstitial pneumonia pattern. The idiopathic pulmonary fibrosis has been very well studied. It's a type of ILD which has been very well studied because it is predominantly found in the West, and there has been documentation about the various CT patterns, wherein you have the history, you have the clinical examination, you have the CT picture, and you can clinch the diagnosis of idiopathic pulmonary fibrosis, and no further evaluation is needed. So this particular pattern, which is seen in IPF, is known as a usual interstitial pneumonia pattern. It is said to be subpleural basal predominant. So the ILD in IPF is usually subpleural basal. There are reticular abnormalities, or there is interstitial septal thickening. there is honeycombing with or without traction bronchiectasis, and there are absence of features which are listed as inconsistent with UIP. What are the features that are inconsistent with UIP? You have a predominant ground glass, you have a predominant nodules, you have predominant consolidations, you have predominant cysts. These go in favor of other ILDs. They don't go in favor of IPF. So the CT picture, as we have seen here. So basically you see it's a basal predominant disease where you have interstitial septal thickening and where you have these, as you see, these stacks of cysts. These are also known as honeycombing. Is classically in the given clinical picture context is a UIP pattern on the CT. Mind you, a UIP pattern on the UIP term is also used for by the pathologist for histopathological for biopsy analysis in ILDs. But the CT scans also, the radiologist will report this as a UIP pattern. You as a pulmonologist or a clinician will say that this is a case of idiopathic IPF. So when you have a patient with a given 70-year-old man with cough, breathlessness, X-ray showing reticulonodular opacity, is a spirometry showing a restrictive abnormality, and the CT showing a UIP pattern, it is an idiopathic pulmonary fibrosis. Okay. Now there are certain other subclassifications. You may not see the classical UIP pattern anyway. So there is something known as a possible UIP pattern. Here also they say that diagnosis is mostly in favor of IPF, but you would have everything, but you would not have honeycombing, or there would be something known as microcystic honeycombing. Okay. So you should have subpleural disease, you should have interstitial septal thickening, you may not have honeycombing. Okay. Early IPFs or early ILDs can often have this pattern. Now there are certain features which are inconsistent with the UIP pattern. It doesn't say that the patient doesn't have ILD. It just says that the possibility that this patient has idiopathic pulmonary fibrosis is less likely. So what are they? If you have upper or mid zone predominance, if you have peribronchovascular involvement, now this is mostly seen in sarcoidosis or airway centered ILDs. If you have extensive GGOs, then it is not IPF. If you have nodules, then it is not IPF. If you have multiple cysts, okay, these, I mean, cysts, they are well-defined regions. I'm not talking about honeycombing, but you have discrete cysts, isolated single cysts which are multiple distributed in the lung. Then that is not IPF. If you have air trapping, so how do you identify air trapping? This is the reason why you need expiratory scans on an HRCT. So black and white areas on a high resolution computed tomograph are known as mosaic pattern. When you do an expiratory scan and when there is exaggeration of this pattern, it is known as mosaic attenuation, and this often is due to air trapping, and this is one of the clinchers for diagnosis of a chronic HP. Okay. And then even a consolidation in any on the CT scan is a feature inconsistent with the usual interstitial pneumonia pattern, which is seen in IPF. So if you have to depict, or if you have to see the CT features of UIP would be basically they would be basal and they would be subpleural. So the involvement you see, there is interstitial septal thickening, there is honeycombing, and at places you will see you see the bronchus has been tracked. There is a traction on the bronchus. So this is known as traction bronchiectasis. So it is depicted in the picture here. So this is honeycombing. There is a subtle GGO, but it is not very predominant. Okay, it's not a predominant finding. You have reticulation or or you have linear opacities or reticular or interstitial septal thickening, and you have traction bronchiectasis. Again, there is a subpleural. It is subpleural in nature, and there is something known as an apico-basal gradient. That means the physes are spared and the bases are more commonly involved. This is classically how a CT will look in a patient of IPF. Okay, this is again the similar picture. We have the actual view here. So basically you will see there is interstitial septal thickening. Okay, all this. Then there is, these are stacks of cysts one about the other. So this is honeycombing or honeycomb lung. And at places you can see that there is this bronchiolectatic area. So this is traction bronchiectasis. Okay. Now, an evaluation of ILD in most cases would stop at the CT. However, there are ILDs wherein advanced or say interventional pulmonology does play a role. Okay, it is not used for idiopathic pulmonary fibrosis. You don't need to do a bronchoscopy or any high-fi IP procedures for a simple IPF. You get the diagnosis on the history and the radiology and the spirometry. Okay, so what are the various investigations that we do? So first is a bronchoscopy, simple bronchoscopy. Now, it is often when we deal with diseases like sarcoidosis, vaginal granulomatosis, there are endobronchial lesions or the biopsies of the bronchial wall and the tracheal wall, if they are abnormal, can yield granulomas and can help us in clinching the diagnosis of these diseases. And they are often very simple because we tend to do bronchoscopy day in and out for malignancies. So as pulmonologists, we often do biopsies in sarcoidosis or in vaginal granulomatosis, transbronchial lung biopsy. Basically, wedging your scope in one of the segments of the lung, usually the lower or the lower lobes, and going to the periphery of the lung till your forceps can go, and taking a biopsy is often found to be diagnostic in ILDs like sarcoidosis, in HP. Okay. So there are two types of biopsies that are done usually with a bronchoscope. One is known as a transbronchial lung biopsy. What do? You take a bronchoscope, go till the end or the edge of the segmental level you could go. Subsequently, send a forceps in. You will meet resistance. Withdraw the scope, open the forceps, and take a bit. Okay. Recently, and in centers like the AIMS and the postgraduate PGI, postgraduate institutes, something known as a cryobiopsy has been often, done. We have seen that the transbronchial lung biopsy often gives us a small tissue, and it often doesn't help in diagnosis of interstitial lung diseases, many interstitial lung diseases. So, to get a better tissue yield or a larger tissue yield, there is something known as a cryobiopsy which is done. It is again done with a bronchoscope. However, it is done under general anesthesia or with the patient under general anesthesia. There is something known as a cryoprobe, which is sent till the periphery of the lung, and there is basically, the lung tissue is freezed and a bit of it is taken out. The cryo tissue or the bits that you get with a cryoprobe are usually larger in size as compared to a transbronchial lung biopsy, and it's said to be better in yielding the diagnosis of ILD. The concept of having biopsies in ILD has come from the 80s and the 90s era. When ILDs were diagnosed, they were diagnosed on the basis of a clinically different situation, not a typical asthma, COPD, a radiology X-ray that is different, and often a lung biopsy, often open lung biopsies were done that time, and the histopathologists saw something different. So biopsies were very frequently done in that era, and there's a lot of literature of that era. However, as CT scans started coming into practice, day-to-day practice, the use of biopsies in common interstitial lung disease is going down. Often our patients are not stable, they are hypoxemic, and they are not fit for the procedure. And that is why we more so diagnose interstitial lung disease with clinical and radiological correlation, and these tests are preserved for a few cases like sarcoidosis or HP, or where we have predominant GGOs, predominant nodules, to understand what is this. Okay, so how do you do tissue biopsies? We don't jump on to do bronchoscopies in every patient. It is always important to remember that it is not required to make diagnosis in all patients with ILD. Your approach should go from a least invasive to a more invasive approach. Just because there's a lymph node in the subcarinal region does not mean you subject a patient of ILD who has a saturation of 90 to the most fanciest one investigation known as IBUS, which has come in. Okay, you need to basically biopsy the least invasive site as much as possible. So in cases like sarcoidosis, you can have a peripheral lymph node like a cervical lymph node or an axillary lymph node, which may be easily targeted. often the Mantu site in sarcoidosis, there is something known as Mantu energy, and after some time, 4 to 6 weeks, the Mantu site develops a nodule. The biopsy of these nodules also have shown granulomatous, granulomatous disease or granulomas, which suggest non-necrotizing granulomas, which suggest sarcoidosis. Okay. So coming to when is a lung biopsy indicated, there are many ways to do a lung biopsy. We as pulmonologists do it in the semi-invasive way by the bronchoscopic route, but the surgeons or the thoracic surgeons can also do the lung biopsy. Initially it was open lung biopsy, then now there is VATS. Okay. Now, these biopsies are more so indicated, or it could be CT guided if it is accessible to the CT guided biopsy, because CT guided biopsies are also less invasive as compared to an open lung biopsy. Okay. So when you have to exclude a neoplasm or an infection, I will go in and target the site with a CT guided biopsy. It is less invasive, more tolerable, and quite sensitive and specific for the diagnosis. Okay. It often, the lung biopsies, especially the VATS guided lung biopsies, are done in ILD where you have a typical pattern or a progressive pattern or an atypical picture, or you have a younger patient. Okay. It is said that you should never do a lung biopsy as per guidelines when you have a patient who is more than 65 years of age, when there are systemic symptoms like fever, or there is absence of systemic features, there are absence of extrapulmonary. So this is basically an IPF-like picture. So when there is no known cause, there are no extrapulmonary manifestations. If you have a family history, you don't need to do a biopsy. It is a familial ILD, mostly IPF. Okay. And when you have stable lung functions, you don't need to jump to a biopsy. Okay. Even when you jump to a biopsy or counsel the patient for a biopsy, there is a lot more to just doing a biopsy. There are a lot of risks involved. A simple transbronchial data of say around 60 consecutive patients of ILD, wherein a transbronchial lung biopsy was done, at least there was a risk of pneumothorax in 1 to 5% of patients, which often led to an ICU stay, insertion of intercostal tube, etc., as per a paper published from our own center. So what is ILD? ILD diagnosis is now multidisciplinary diagnosis, or it is MDD. So the ILD is diagnosed by a pulmonologist with the help of, most importantly, a radiologist. The radiology pattern of the CT picture is very important in the diagnosis of ILD, and rarely you can have the pathologist and your rheumatologist or the dermatologist, all this in correlation, giving you a diagnosis of an interstitial lung disease. So it is said that the correct IIP diagnosis needs teamwork and experience. So how will you diagnose a case of ILD? So when we diagnose a case of ILD, we always say interstitial lung disease, idiopathic interstitial pneumonia versus a known etiology. Suppose you have a CTD, so I will say ILD, connective tissue disease associated ILD, or I subclassify the ILD depending on the pattern on the CT scan. Okay, it is important to document the comorbidities and complications in your diagnosis. So I will say I have a patient who is a 70-year-old lady who's a case of interstitial lung disease, idiopathic interstitial pneumonia, mostly idiopathic pulmonary fibrosis, the subclass, with hypertension, diabetes, or whatever the patient has. And if she has some complications, like 2 weeks back, we had a gentleman who had IPF and who had come with a pneumothorax. So with pneumothorax, with an intercostal drain in situ. Okay. Why? Because these comorbidities and complications are amenable to therapy, and they can definitely improve, on proper treatment and identification. So complications like a pneumothorax, a thromboembolism, an exacerbation should be identified and treated, as they help in improving the symptoms of the patient and stabilizing the patient. Okay. In an ILD, a functional assessment is must. Okay. The functional assessment just does not involve a spirometry. It also involves a 6-minute walk test if it is possible. Okay. And most importantly, once you make a diagnosis, even before you think about writing pharmacotherapy or pulmonary rehab, the first important thing is to sit down quietly with the patient and counsel the patient. It is not easy to digest the diagnosis, especially in the tertiary care center, we have patients who have jumped or who have gone from doctors to doctors and come to us. Why? मुझे दमे का तकलीफ हो, I have breathlessness, I have gone from this doctor to that doctor, they try all medications, but they have not been able to cure my breathlessness. It is difficult to say that, you know, this is a breathlessness with which we need to teach you how to live with. But at times, this has to be told to the patient in a good way, in a way where we positively motivate the patient, tell the good things to the patient. So like the lady who's admitted with me, she is an elderly lady, her lung functions are normal. She often says, I have cough and breathlessness. I said, look at the patient who is next bed. She is a 30-year-old. She has connective tissue disease. She is oxygen requiring patient, whereas you are a 70-year-old lady. Yes, you have dyspnea on walking, or you have breathlessness on walking, you have cough. I understand it, okay? But this is due to the interstitial lung disease. It is a progressive, or it's a chronic disease, and it is often slowly progressing or progressive in nature. It's like aging of the lung. Like you do not have any medications to, you know, prevent yourself from aging. There are not any medications to prevent this particular disease from progressing, but there are a lot of medications or non-medical measures in which way you can feel less breathless and your symptoms can be alleviated or they can be controlled. I do not attempt to cure your disease, is what we have to tell the patient clearly in a case of ILD. Because many times this is often not told. Doctor Saab ne, I mean, the doctor has seen me, has given medication, but my cough and dyspnea is not better. Okay, so you need to say that the medications are usually not to cure the disease. Maximum, they aim to prevent progression. It is not, there is no going back here. It is like an aging process, and you need to understand it and you need to learn how well to live with it. So, to counsel the patient, we ourselves should know how do ILDs behave. And this is a graph from one of our guidelines on interstitial lung diseases. So it is said that interstitial lung disease patients can, 1/3 of them have rapid progression. So they will have a median course of, like, you know, say survival of 2 to 3 years. They will progress subsequently, will eventually require oxygen and will be, you know, disabled in the form of they would be bed bound or they would be dependent on the oxygen. Many of the patients, 1/3 of the patients may have ILDs, especially CTD related ILDs, HP, fibrotic NSIP. They all have a very slow progressive course. So we need to reassure them, counsel them, optimize the conditions which can be treated like comorbidities. They can have uncontrolled diabetes, hypertension. They can be treated for the gastroesophageal reflux disease that they have. Okay, and encouraged to continue the pulmonary rehab. Okay, very rarely you may have patients with a stable course. Okay, rarely you have diseases like acute HP, or you have diseases which will come to next, the post-COVID, you know, ILD, which often improves drastically. Okay, so in these ILD cases who have a slow or a stable course, sometimes you can have an acute exacerbation which may cause a sudden fall in lung function and may require hospitalization. You should be aware that this is the natural course or the natural way an ILD progresses. So if you are aware of the course, you can easily counsel the course to the patient. Okay. So often a patient comes to you in your outpatient department and the first question the patient asks you, so what, doctor? That means I am not going to live further, or that means, you know, I will always be breathless and I will always have the cough. Okay. So there are certain, you know, certain parameters on which we you know, identify the prognosis, or, you know, probably, you know, try to make a prediction. There are so many tools in if you go to the MD Cal or the calculators which we have, you have the GAP IPF, GAP ILD, but let me tell you, no calculator is accurate. Okay, so these are all percentages and no calculators are accurate. You need to tell the patient what is good with you. Yes, these are the problems with you and what best can be done for these problems. As a follow-up, to understand whether the ILD is progressing, okay, we do a symptom check. This is usually a follow-up. Suppose we decide to treat the patient with some therapy, we do a first follow-up at 1 month and then subsequently a 3-monthly follow-up. If we are just keeping the patient under observation or the patient is on oxygen therapy, okay, then the follow-up is done in such a way that the patient doesn't have to again and again come to the hospital. If you have to again and again come to the hospital, that involves a lot of exertion, which is going to make the patient breathless, and out of breath. So a symptom check at follow-up, a simple spirometry at follow-up, a 6-minute walk test at follow-up, a 1-yearly HRCT if the patient is doing well, and a 2D echo once in a year is done. The spirometry, the symptom check, spirometry, and a 6-minute walk test is easily done in the outpatient department and can be done at every 3 months assessment. What do you understand? The ILD guidelines say that when you have a fall in FPC of more than 10% and DLCO more than 15%, mind you, many of your patients may not be able to perform a DLCO, and if you are in a clinic setup, you may not have access to a DLCO machine, but then the simple spirometry is more than enough. Okay, so and the 6-minute walk test is they are prognostic markers. So when there is a fall in these with symptom progression, you often know that this is a progressive fibrosing interstitial, or PFILD as a new term is a progressive fibrosing interstitial lung disease, irrespective of whatever it is. It is a HP or an IPF or a fibrotic NSIP, it is progressing. You need to make this aware to the patient as well as the relative and make the patient ready for the subsequent progression and probably assess in advance for oxygen therapy and other things. So how do you treat a patient? When I have a patient of stable ILD coming to an outpatient department, the first thing that I need to ask the patient is, what have you come here with? What expectations have you come here with? Often the answer in most of the cases is, I've gone to 3-4 doctors, I've met 3-4 doctors, they've given me multiple medications, they have not been able to treat the disease. So you start off with counseling the patient on understanding what is an ILD. What is it actually? This is a disease which is like the aging of the lung in predominant cases. Okay, most of the cases of ILD in an elderly, it is like an aging of the lung. It is occurring prematurely before your age, and that is why you feel the same. Okay, my job is not to cure the disease. My job would be basically to probably try and prevent progression and to alleviate your symptoms, or to try and help you out with your symptoms. So as we all know, what helps best with the symptoms is a pulmonary rehab. If you Google, there is a website by the American Lung Association wherein it used to be living with pulmonary fibrosis earlier, but now it is living well with pulmonary fibrosis. And this website gives it's good for doctors also to read it. It gives very good information about things like, doctor, I'm breathless. I get breathless when I have food. How do I get about it? I get breathless when I walk. How do I go about it? And in very simple, short answers, they have described how can one live well with pulmonary fibrosis. Hey, it's a very good website even for the educated patients and their relatives to go through. Okay, and yes, we all know pulmonary rehab consists of physiotherapy, which includes chest physiotherapy, breathing exercises, gradual ambulation. The patients are often breathless when they try to do the work. Basically, they are used to a certain activity and they try to do it in the same pace. You need to explain to them, you may not be able to do the activity in the same pace, in the same speed, but you will be able to gradually do it, and that is what the physiotherapist or the rehab specialist will teach you. And how you can do, suppose going out for a walk. Yeah, like 3 years ago, you would go out on a walk and you would come back, you would take, say 10-15 minutes walk, you would never feel breathless. But now there is a possibility that you go out, you may feel breathless. So you should do the activity in stages. Simple things like in our ward, when we start explaining our patients, the patients often say, I go to the bathroom and I get breathless. I said, go walk a little distance, sit on the bed near or take halt a little while, catch a breath, and then go ahead and go to the washroom. So you may be able to do it in graded manners, but please do it. I am breathless, so I will sit in one place. When I am better, I will move around, should be strongly discouraged. Even patients who are stable on oxygen should be encouraged to do activity in bed, getting up of the bed, from the bed, sitting in the chair with the oxygen on, because it helps in preventing further complications. This helps in preventing muscle wasting and the accessory muscles of respiration, which are going to be very important, will remain active. Okay. Then comes diet. Our patients of ILD often say, I cannot eat a plate full of food. I just eat one chapati and I'm breathless. So you have to explain to them that this all is because of the lung disease, and because your diaphragm is at a disadvantage, or because of the disease that you try to have a lot of food, there will be gastric distension and you are going to often get breathless. How do you overcome this? You try small frequent meals, and when you are not able to eat anything, you can take protein supplements, or you can consult a dietitian on high energy foods that can be taken. It's like you have protein snack bars or protein powders which can be taken. So the physiotherapy, gradual ambulation, and diet, these are common problems, So they suddenly see that in the last 2 years I'm not eating, and the relatives are often, the son or the daughter says she's not eating anything. You need to tell them, don't worry, she'll be given a diet chart, and you should give it as per, you should give the meals as per diet chart. You expect your patient to eat a plate full of food may not be possible. This is often because these patients often develop breathlessness when they have a lot of food, altogether. We should optimize all treatable comorbidities. The hypertension should be treated, a cardiac problem which is amenable to treatment should be treated, a diabetes which is amenable to treatment should be treated. Mind you, these are common comorbidities. Every third person in India has diabetes. So this should be treated so you don't have other problems related to these diseases. Okay, just because I have ILD now, now I don't know what will happen to me in future. I'm not going to take any treatment for diabetes. They should be explained. They should be made to understand that if you treat your diabetes properly, you will not have problems related to diabetes. And many times ILD may not need an hospitalization, but complications related to diabetes, hypertension, or heart disease may need admissions. Okay, we need to vaccinate these individuals. I'm sorry, I've forgotten that point. Most importantly, admissions in any patient with a chronic respiratory disease are due to exacerbations. What causes exacerbations? Most commonly infections. Which infections? It has been proven that they are mostly viruses. The influenza vaccination is a level A evidence, and the pneumococcal vaccines also have a level B evidence. Both these vaccines should be given to the patient. These prevent future admissions in patients. So we should always look at preventing an admission in our patient. Why? If we prevent an admission, any admission in any patient, irrespective whether it's ILD or COPD, will cause a fall in lung function, and would not, the lung functions are said, it is said that they don't go back to the normal. And hence, it is always targeted to aim at preventing an admission. Okay, we need to treat common comorbid condition in our patients, which is depression or anxiety. Depression often, as many of our patients are breathless, they often worry about the breathlessness, and they may have depression or anxiety, and this should be treated by the concerns by referring to the psychiatrist. Okay, now there is some specific pharmacotherapy in ILD. However, doctors who see ILD day in and out will tell you that none of these therapies really help unless it is a disease like sarcoidosis. It is a disease like connective tissue disease related ILD. So we will classify the diseases as IPF or progressive fibrosing interstitial lung disease. Listening to the history, seeing the reports of the patient, we often have patients being, going to 2 to 3 doctors and coming to us. We often understand that this patient is having a progressive lung disease. It is fibrosing in nature. So we have a progressive fibrosing interstitial lung disease. Most often in an elderly individual, it is IPF or a fibrotic NSIP or an chronic HP. Now, in IPF, there are certain antifibrotics, or these are group of drugs like the nintedanib and the pirfenidone, which have been known to prevent fibrosis. Now, mind you, they should be used in patients And the studies or the trials which have studied antifibrotics have studied them in the early stage, where all studies, if you see, they have studied pirfenidone and nintedanib when the FVC of the patient was between 70% to 50%. So, especially where I sit in a tertiary care center, I often have patients who usually have an FVC less than 50% by the time they reach us. Okay? And that means the fibrosis has already occurred. What are the antifibrotics you want to do in a patient who already has a fibrotic lung disease? Nothing. They will just add to the pill burden. They will add to the side effects, and a sensible decision is to be done, made whether they are candidates for antifibrotics or not. Okay, because and when you start antifibrotics, you need to reassess for the tolerability and benefit. It's not that you start and it's a lifelong treatment and you give it for lifelong. When you see the patient at follow-up, in spite of being on antifibrotics, the patient's lung function, the symptoms show progressive decline. The spirometry shows a progressive decline. You know your antifibrotics are not working. What are you doing? The antifibrotics should at least halt progression. They are not doing it. And what's the point in taking these drugs? So we have to always reassess for tolerability and benefit. The doses for pirfenidone, usually now it comes in an 800 milligram tablet. Previously it used to come in a 200 milligram tablet. If they are given in the doses of 800 milligram TDS, then it comes and commonly available as a 200 milligram tablet. It is often escalated as 1 tablet TDS to the next week monitoring the LFTs, to 2 tablets TDS to 3 tablets TDS. It is not easy to take 9 tablets in a day. You or me, we both will be a little reluctant when we are told to take 9 tablets in a day. Okay, so please reassess the benefit and please reassess the need and please reassess for the tolerability of any pharmacotherapy, especially the antifibrotics, when you give in these patients. Yes, there are a group of interstitial lung diseases like, where there is predominant GGOs, nodules, or sarcoidosis, or even our post-COVID ILD, where steroids or steroids with immunosuppressants have shown to be very beneficial, and they have slowed the progression. Okay, and they tend to improve symptoms. So in the correct patient, like a young patient with a connective tissue disease associated ILD, I will treat the patient with steroids in a dose of say 0.6 to 1 milligram per kg per day, not exceeding 40 milligrams now as per the latest guidelines, and with immunosuppressants like azathioprine or cyclophosphamide. Again, when you are treating CTDs, please remember you are not the only one treating the patient. You have a rheumatologist, you have a dermatologist, and the patient may have those systemic manifestations. It should not be that a patient is taking double doses of steroid. They are giving one, you are giving one. Treatment should be in synchrony and in discussion with the dermatologist and the rheumatologist if they have those organ manifestations. Okay. Now there is, as I explained, that often you have an acute exacerbation of interstitial lung disease coming to our ICUs. Yes, it's a critical disease. These patients need to be hospitalized. These patients are treated like other critical patients, wherein oxygen, NIV is the mainstay of therapy. Okay. Now the only drug which is shown to be of significant, importance or improvement in ILD, especially acute exacerbation, is prednisolone. There is enough evidence that when prednisolone given in the dose of, we give a dose of 40 milligram per day, but in a dose of 0.6 to 1 milligram per day for or equivalent steroids. You may not give oral prednisolone, you may give other equivalent doses of the prednisolone for 14 days. It is said to have a definite, good impact on the acute exacerbation of ILD, and any ILD in exacerbation should be given a steroid course for 14 days. Okay. Moving on from our interstitial lung diseases to post-COVID interstitial lung disease, it is also, there are various terms used in literature. So there is something known as a long COVID. Now, mind you, long COVID may just not involve the lung, it may involve other systems also. But often there have been articles wherein they have described post-COVID ILD as long COVID. Then there was a term which came, which was post-acute sequelae of COVID, so PASC. Okay, whatever it is, We all know that in the wave one, where we saw non-vaccinated or unvaccinated individuals, we had COVID pneumonia often presenting or progressing to with a cytokine storm, progressing into an ARDS-like picture. Okay, and this, when it resolved with pulmonary fibrosis. Now, mind you, not all patients behaved in this way. There were a group of patients who had ARDS and they succumbed to the disease. There were a group of patients who had ARDS and they gradually improved, and they improved significantly, and by the time they discharged, they had a prolonged hospital stay as compared to usual pneumonias have, say 21 days, 1 month, or 4 to 6 weeks or so, and they improved on treatment, and they were often discharged without oxygen at home. But when a repeat x-rays or repeat radiology was done, they had residual symptoms. They had x-rays or CT scans showing the previous lesions or GGOs, ground glass opacities, have now evolved into pulmonary fibrosis. Okay, and there were some individuals whom we have discharged even on oxygen. Okay, so is this something new, or is COVID one of the only viruses that causes pulmonary fibrosis? No, it is not so. In COVID pandemic or in COVID, we saw numbers. That is why we saw number of patients come, progressing into this stage, and it came into the limelight. H1N1, when you have bilateral pneumonia due to H1N1 infection, or what you known as the swine flu, it is known, and we have seen patients that are infectious disease hospitals where often they present with the similar picture like ARDS, and then they often progress to a pulmonary fibrosis. However, this fibrosis has a very good outcome, and these patients tend to do very well like our COVID patients. So as we all know, in COVID, the acute phase was most challenging in the wave one. If the patient survived this acute case, then sequelae like an ILD or pulmonary fibrosis developed, and which usually resolved with time or improved with time, and it had a good prognosis. And often steroid treatment or therapy, they were treated by like the good ILDs, okay, or the non-IPF ILDs with steroids. Okay, now what happened is, when we went from wave 1 to wave 2 to wave 3, we had vaccination, vaccinated individuals. Surprisingly, in vaccinated individuals, we never saw lung involvement, and this particular a disease entity of post-COVID pulmonary fibrosis or post-COVID fibrosis were majorly restricted to the wave 1 patients. Now we do not see patients, or we see patients extremely rarely when they have a lung involvement and which progresses to a fibrosis. The normal healthy individual never does. Whether the immunocompromised group has a predisposition or not, time will tell. However, in practice, or what papers we have been reading there, the vaccination has shown to minimize lung involvement, and since there is no lung involvement, there is no sequelae. Okay. So we aim not at treating COVID fibrosis now in the vaccination era. We aimed at vaccinating, and the job is done. And eventually, the COVID virus has turned down into a milder variant, wherein it has it basically affects individuals and causes mainly URTI like symptoms. So why did the COVID virus or the SARS-CoV-2 cause pulmonary fibrosis? There were multiple hypotheses, and this is taken from 2 articles, one by Dr. Raghu et al. And one by Dr. Udvadia. One says that the SARS-CoV-2 causes a downregulation of the ACE2 receptors, which we all know, which causes an increase in the angiotensin 2 levels, and this eventually has an impact on the tumor growth factor beta levels, which increases. This in turn causes myofibroblast activation and extracellular matrix accumulation. These are basically the causes of an ILD. What causes the fibroblasts to cause fibrosis and the extracellular matrix to accumulate is different in different types of ILD. So this was the hypothesis in the SARS-CoV-2. In addition, we treated this patient with a lot of oxygen. You had a patient with COVID pneumonia, and then there would be a non-rebreather mask and full oxygen given. As pulmonologists, we have always been taught it used oxygen judiciously. Why? Because there is something known as oxygen toxicity or hyperoxia effect. So a part of the lung fibrosis was also suspected to be due to the excess of oxygen that these patients received and the hyperoxia. There is again ventilation associated lung injury, which also contributed to the lung fibrosis. Again, there was a hypothesis in a 2021 article, which is true actually, that most COVID positive individuals who had severe pneumonias, they did very well and they were improving. And this was the most common course of the patients. There were some very rare who were static, and this was who were very static and who required, probably oxygen therapy even after discharge, and they remained on oxygen. A less common group was one which progressed. As we see patients coming in after the pandemic, coming out of their homes from the pandemic, we have also seen patients who have been RT-PCR negative and who have been labeled as COVID. It is not COVID, but it is an interstitial lung disease, either an idiopathic cause or some known cause, which was in the COVID pandemic. Everything that was cough and breathlessness was taken as COVID, which is treated as COVID, and they are actually PF-ILDs who are now presenting to us. In COVID, basically, we saw some patients who were severe ARDSs who did not do well. They could not be discharged from hospitals, and they had a declining course. Okay, so these are CT scans of a patient with a bilateral COVID pneumonia who had an intensive ICU stay, required NIV. You see the first CT scans show, which were done in the week 2 of the disease, or the day 7, day 10 of the disease, when the patient came in with cough and breathlessness, show basically bilateral consolidations and with a lot of GGO. So this, what you see white, is a consolidation, and this which you see like a glass-like effect is where my arrow is pointing, is a ground glass. The difference between a consolidation and ground glass is, in a consolidation on a CT, you will not be able to identify vessels separately. In a ground glass, you can see the intervening vessels. This is the difference. Okay. Then the patient recovers after 21 or say 24 days of hospital stay. Eventually, as the patient requires oxygen therapy, as he's improving, he started on a course of steroids also. The patient subsequently is discharged, or say at 1 month of follow-up, comes with a CT scan where you have interstitial septal thickening. There are certain, the GGOs have gone, the consolidations have resolved, and there is some interstitial septal thickening. The patient follows up at 6 months interval, and you do a CT. And this is a very common finding, and we've seen more than 50 to 60% patients who have, opacities have just disappeared. The ideally fibrosis doesn't go back. Okay, but since this is an infective or an inflammatory insult, and it is steroid responsive, and you see the CT scan here is almost near normal, some subtle fibrosis here and there. However, the CT has improved drastically. This is one of the pictures. This is the classical radiology which we saw in a lot of our COVID survivors from the ICU who had ARDS. They did very well, and it was a pleasure to the eye to see these, to see them clinically improved. 30-year-olds. I mean, we dealt with healthcare workers in COVID, so our own doctors, our own professionals, when they were so bad, and they were NIV requiring, we didn't know what will happen tomorrow. And when they recovered, when they went home, and when they came for a follow-up, and the CTs were completely resolved, it was like seeing a miracle. So the discussion on ILD is incomplete without a word or two on something known as the ILD India Registry. So the ILD India Registry was started as an initiative way back in 2013-14, wherein an attempt was made to understand what is ILD and how is ILD and what is ILD in India. So there were 1,084 patients which were recruited in this registry. In the Western India, our hospital and our department was one of the major centers which contributed to around 140 patients. Okay, this registry results came out that in India we saw HP as a common ILD, which was 47%, which was seen around 519 patients. There were a lot of patients, and there was a lot of bias towards patients from the north here. So there were patients from northern centers, and there is these areas being dry, arid. There's a lot of use of air coolers, which often contain humidity and fungus. And there was a hypothesis that probably there is HP more because of these. There was some correlation with the air coolers. Okay. At our center, when we analyzed our data, we found that our data, more so being probably a metropolitan city, we mimicked the West. We still saw HP as a second predominant ILD. Our first predominant ILD was IPF. This was, however, when in contribution, when the whole of ILD India registry showed the results, and HP was a predominant ILD. The next was CTD related ILD, and IPF was seen in 13.7 patients. So a word or two about HP. Acute HP is something like, a pneumonia, like a serious disease where the patient is critically ill, needs an ICU stay, is often hypoxemic, and the CT done shows GGOs, and it has got very good response to steroid therapy. Even a subacute HP, we have seen subacute HP on exposure to pigeon droppings, to lovebirds, okay, wherein the patients are stable, they come walking to the OPDs, though they have a desaturation to the tune of say 89-90%, they have post-exercise desaturation. They often have similar picture of GGOs with some fibrosis in the background. They have done very well on a steroid therapy for say a duration of 6 months to 1 year. And then there is a common type of HP which is diagnosed now after the ILD India registry results, which is chronic HP. This is often the history, the radiology of this HP often mimics like that of an IPF. Means it's the progressive fibrosing interstitial lung disease. There is chronic cough and breathlessness, and there is progressive fall in the lung functions, progressive forms in the functional assessments that we do. Only thing is, when you do a CT, you do not have a classical UIP pattern, and there is air trapping on expiratory scans. Yes, so it is said that especially in subacute and acute HP, you are often able to identify a significant exposure. So you should first remove the exposure. So the gentleman who had exposure to lovebirds, the first thing that we told him, before we treat you have to get rid of, you have to let go of the lovebirds. Understood, no? Because that is what has caused this ILD. So you have to let go of the exposure first, remove the exposure, and treat with steroid, especially acute and subacute HP. So to summarize, interstitial lung diseases are a heterogeneous group of disorders. A clinical suspicion is usually based, a clinical diagnosis of ILD is usually based on the clinical presentation on X-ray. As I said, a classical ILD is often seen in practice. You will have every fifth patient coming to you with this elderly gentleman, or say somebody beyond the fifth or the sixth decade with cough, breathlessness, which is usually chronic in nature, has basically exercise desaturation or baseline desaturation, has clubbing, and has bilateral fine crackles, and you do an X-ray, and you get an X-ray in half an hour, and there are reticular nodular opicities on the X-ray, and we clinch the diagnosis of ILD in absence of any etiological factors, any exposures. It is mostly IPF. Okay. Now, you need to evaluate ILDs further. A basic high-resolution computer tomogram with expiratory scans would be done in all ILDs. But whether to do advanced tests, whether to do biopsies or not, would depend from case to case. Yes, you will do a basic clinical evaluation, basic blood test, a basic X-ray and HRCT, spirometry in all these cases. Okay, as I said, all cases do not require lung biopsy. There are diseases which we commonly see, which are idiopathic pulmonary fibrosis, connective tissue disease related ILDs, and chronic HP. This can be very confidently be diagnosed with multidisciplinary discussion and in clinical radiological correlation. We rarely need to do biopsies in these cases. Okay, and CT picture with the history and the clinical examination is usually diagnostic. In any ILD, especially the ones which are chronic and progressive, the counseling is the cornerstone to make the patient understand the disease is most important. We often admit patients for this, basically to make them understand the disease and to make them aware that you will have to live with this and how well to live with it. So doing pulmonary rehab is very important. You will often see us talking about physiotherapy, vaccinations, comorbidity optimization, and less on, antifibrotics or, probably pharmacotherapy. It's more of counseling and rehab that we do. And these are the major cornerstones in managing any interstitial lung disease. I thank you very much for having me here and for making me take this section. Thank you, madam. Thank you.
Thank you so much, Unnati.
Yes.
And it is like reminded me of my 3 years of Nair in 1.5 hours. It's not easy to talk on interstitial lung disease. So thank you for that. We can stop screen sharing. The only 2 points that I would like to add after Unnati's extensive talk is one about palliative care, which obviously counseling was a big part in her talk. But from my experience, where pulmonologists probably don't find the time to, and naturally so, because of the busy OPDs, is very important to integrate palliative care because it really helps patients and caregivers. There was a question in the chat box which I answered about how and when palliative care should come in. Unfortunately, I think the term palliative doesn't go very well with pulmonologists, and they think it's like giving up. While I think we focus on improving the quality of life of patients, especially now we have started seeing younger patients with ILD, and it can be really difficult. And we have one more option available to the ones who can afford to try, which is lung transplant. So, it's the decision between the devil and the deep sea, where the patient becomes a patient of transplant from an ILD patient. So that transition also, the support of the palliative care helps. And the second point is end of life planning, because interstitial lung disease patients fare very poorly on the ventilator and ideally should not be on the ventilator. And it's extremely important to start talking the difficult dialogues of planning end of life when you see the patient is on the slippery slide down, and not burden your health resources by admitting patients of interstitial lung in the ICU. So careful selection, discussion, communication, documentation of end of life, very, very important. And these are the patients, often we start doing the morphine, the oxygen, and we also train the GPs of how to handle these situations at home. And for aggressively treating their symptoms, very often we do use the drips of, we do use subcutaneous infusion of a combination of morphine and midazolam so that the patient transitions in peace. I know that there isn't any time and everybody must be hungry. So in case there's any pressing question, please ask. Otherwise, send your questions to us. We don't want to keep you more away from your family and dinner. But if there's anything which is important, send it to us. I will try to answer in the subsequent sessions. Thank you very much, Unnati. Over to you, Rajlakshmi. Are you there?
Yes, ma'am. I'm
Thank
there.
you, madam.